So now we are recording and I can start. Thank you very much again for all of you to join us today. It's an honor and a pleasure to host this meeting from OR Asociación in Spain, together with the Histiocytosis Association and Erdheim Chester Global Alliance. It's so amazing to have you all in the room, especially the adult patients that are connected from everywhere in the world. Let me start by the technical part. We are editing this meeting today. We are going to record it in order to be able to share it with you and the people that are not going to be able to connect today. Please send us the questions that you have to the question and to the question and answers, the Q&A button that you have in the bottom of your menu. And very important is that today we have the translation, the interpretation channel that you have available. So please feel free to use it. In Espanol is the channel that you will hear the interpreters. And in case you want to hear the original version, you need to select the English channel or just put it off and you will hear the original version. So the agenda for today is I'm going to just give a few words about the work that we do at OR Asociación. And then we will have Gaurav Goyal, Dr. Gaurav Goyal from the University of Alabama presenting on adult patients with LCH and with Erdheim Chester, and forwarded by Deanna Fournier, which is the CEO of the Histiocytosis Association, and Jessica Corcoran, which is the Executive Director of Ecd Global Alliance. And then we have a general, after each talk, we will have a small question and answer session. And at the end of the talk, we will have a general one. I wanted to start by saying thank you, saying thanks to all of you that are here with us today. Also to the guys that are helping me organizing all these journeys, which are the Histiocytosis Association and the Ecd Global Alliance. Also with the support of the local associations, which we work with for the last years, which is a pleasure to have also their support. The Argentinian Association, the Canadian Association of Histiocytosis, the Artemis Association in Greece, Fundación Natalie Flexer in Argentina, and in Spain here we have La Luita de Arnau, La Sonrisa de Daniela, and Lch, todos contra la histiocitosis. So also very important, and sorry, is to say thanks to Kristen from the Histiocytosis Association, which has also, I feel very lucky to work also with her, and she was also pushing all these global initiatives. So thank you, Kristen, for that. I want to dedicate this journey to the patients, to the adult patients, and here we have some of them. A few months ago, we launched a program in support for their to be supported. So we have a group created now, and I want to dedicate this to Ainhoa, to Gabi, to Marina, Raquel, Susana, Nico, Fina, and Adria, which are in treatment as well. And this is all this work is also for them. So how did we get here? OR Asociación is an association that has been launched in 2012 because, of course, of a personal matter. Always the association starts by a personal matter. Our kids started his treatment in Sant Joan de Déu Hospital in Barcelona, and we discovered there that it was a need.
Fernando?
Yes.
Sorry to interrupt. We can't see your slides advancing.
You can't. Okay, not good. Not good. Oh, I see them. Okay, so let me share them again. Okay. Okay. Do you see them now?
Yes.
Yes.
You may want to switch the configuration on the visualization. to the, swap the view up there. There is an arrow.
Now if I move them, you can or not?
Sure, that's fine too.
Now it's okay?
You can change the view on top if you want, the middle option. If you go at the top of your screen. Oh, this is fine actually.
Yeah. Okay. So I will continue from here. Okay. The idea of our association was to connect between patients and families, and with those families with us to create links with the scientific community. And this is one of the examples that's why we are here today. We believe that we are an important part of as well, and we can influence and we can try to really do the things together with the scientific community, and this is what we are trying to do. So where we concentrate our energies, or what is our aim, is being the advocate for studies being done and to really share the information with the patients and their families, to create a union, as I was saying, with the scientific community and the other parents associations that are also working around us, to promote all kinds of initiatives related to histiocytosis, and to be a bridge between the ECO and the non-English speakers. Means that there is a gap as well with all the doctors in Central and South America and the Iberian doctors, which are not allowed to participate in all the activities because of language matters. So we will try to bridge as well on that. We are funding, and we have possibilities to fund some more research. So this is also a call for the scientific community to get in touch with us and tell us if there are needs for fundings. And we are very interested in the international registration of patients. So we hope that we can participate and help as well on that. This is how we started, and this is a little bit of history of how our association was born and what we did all these years. I won't enter into such in detail, but there was a lot of work being done. We have launched the first, we could found the first study in Barcelona that is currently done in San Juan de Dios Hospital together with these three associations, La Luita de Arnau, Super-H, and Todos contra la Histiocytosis. We did the first meeting in Spain ever of families and parents of patients. We also launched last year, end of 2019, a second study of immunotherapies in Argentina, together with Hospital Garraham. And we have now our own Histio Caregiver Support Plan, which is an honor for us to have it, where we can support families, we can support patients, and we can really get in touch with the families and the people and give them support. This is thanks to the efforts of Hard Rock Cafe Barcelona and Johnson & Johnson, which are allowing us, and they are funding this project. Another great initiative that we are on, and also Diane and Jessica are part of, is the Global Histio. We started last year to collaborate between all of us and many more associations that are over there. I want to share with you a launch of something we did at the beginning of this year, and I think it's very, very nice to see.
Italiana linfoistiocitosi emofagocitica. Sono molto orgoglioso che l'associazione che rappresento sia entrata a far parte di un grosso progetto, un progetto denominato Global Histio.
Desde aquí, desde Argentina, estamos muy felices de participar del lanzamiento de esta iniciativa global para hacer más visibles a todos nuestros pacientes de istio.
Hi, I'm Deanna Fournier, Executive Director of the Histiocytosis Association. We are thrilled to be joined by so many incredible organizations around the world as we spread awareness for all histiocytic disorders and show histio patients and families that you are not alone. Together, we are stronger.
Estamos muito felizes em participar da iniciativa global pela histiocytose e juntos poder trabalhar pela cura. Muito obrigado e seguiremos unidos por nossos istio-guerreiros.
Desde OR Asociación en Barcelona estamos encantados de poder participar en esta iniciativa global, que estamos seguros de que juntos vamos a lograr grandes cosas. Muchísimas gracias y mucha fuerza para los istio-guerreros.
The Histiocytosis Association of Canada is dedicated to helping Canadians affected by all types of histiocytosis. My name is Claudio Di Girolamo, and on behalf of the association, we are thrilled to be part of the Global Awareness Campaign in a combined effort to raise the awareness of histo diseases around the world. Together, let's raise awareness for histiocytosis.
The Ecd Global Alliance is excited about partnering with organizations around the world in order to bring more awareness to histio diseases.
Bonjour, je m'appelle Chénie Nassina, je suis présidente de l'association LHF Espoir, une association française qui soutient les patients atteints de la lymphohistiocytose familiale en France et en Suisse. Ensemble, luttons contre l'histiocytosis.
So that's a symbol of union, and that's something that we are really concentrate on, which is to really start working together, and we are very happy to make that happen. I'm not sure if now my presentation is being.
No, it's your desktop.
It's my desktop. Okay, so
with Iron Man.
Right. Okay, it's back. Now it's back. Right?
No.
No. Yet no.
No.
Okay, things to be with the live connection now.
Got it.
Yes. Okay. Thank you, Gaurav. So this is something very important for us to start working together. It's a unique opportunity that we are having. It's very important that we put things in common, efforts in common, in order to make our lives easier for all of us. So how do we also get funds for our projects? We do all type of events and many fundraising events with books, with bracelets, with the help of companies, football tournaments, Zumba, concerts. So it's a really honor to be able to fundraise and to give funds for the scientific community, and also to fund our own project, the support projects. Another way to collaborate with us is to donate to our association or become a member. There is the possibility to become a member of our association. I will send this link via the chat box, so you also will be able to. So without any further delay, I will present the people today. Dr. Gaurav Goyal, which will be the first to talk. He's an oncohematologist at the University of Alabama in Birmingham. He has more than 120 publications in the ResearchGate, which is a huge work done. And after his talk, Deanna Fournier will talk, and Jessica Corcoran from the ECD Association. So Gaurav, it's all yours. I will answer my desktop and you can share yours.
Thank you, Fernando. let's do this. I want to make sure that we get the slides in the right mode.
Yes.
While troubleshooting. Are you able to see the full screen?
Yes.
Okay. All right. So, hi everyone. My name is Gaurav Goyal. I am an assistant professor, Division of Hematology Oncology at University of Alabama, Birmingham in the US. I would like to thank the OR Association for inviting me to give this talk. Although it would have been nice if I could have done it in person and get to see the stadium myself. When I have to say, when I was first invited, my reaction was that I don't know much Spanish, but I was assured that I will have a very nice Spanish translation voice for this webinar, which is actually much nicer than my actual voice. So I think this will be a great opportunity to work with you. Over the next 45 minutes or so, I will review the diagnosis and management strategies for ECD and LCH. I will only be talking about adults. A lot of the data in LCH is derived from pediatric literature, but I myself treat adult patients with these disorders. So that's where I'm going to be focusing on. And that's the area where I think it's an area of unmet need. Hopefully, we will have ample time to answer any questions that you might have as we go forward. Before I dive into it, I just want to make sure that everybody is okay with the translation. Everything is going smoothly so that there is no issues. Fernando, can you confirm?
Yes, I can confirm, Gaurav. They are hearing you. Excellent.
Okay, good. These are my disclosures. So here are the talk objectives. I'm hopeful that at the end of the talk, the participants, especially clinicians, they are able to describe the spectrum of adult histiocytic disorders. They're able to differentiate between clinical features of common adult histiocytosis. I'll focus mainly on ECD and LCH, but I'll touch briefly upon Rosai-Dorfman disease, as it is important to differentiate between these disorders clinically sometimes, and they can also overlap. And then we'll review the treatment options of ECD and LCH in adults. This is the outline of my talk. I'll start with a case, discuss the classification of histiocytosis in general. We'll review the molecular features and role of targeted therapies, clinical features, overall treatment options. We'll review the cases again to conclude, and then review some of the challenges and future directions. Let's start with a couple of cases from my clinic. First patient is a 20-year-old female in 2006 that she presented with polyuria, polydipsia, diabetes insipidus was diagnosed. She had an MRI of the brain, which was negative for any lesions of the pituitary. She also had amenorrhea at that time at a young age. 6 years later, she underwent an MRI for follow-up, and this time it actually showed pituitary stalk thickening. The pituitary was biopsied and did not show, we were not able to get a diagnosis at that time. Subsequently, in 2013, she developed lesions around her eyes in the form of xanthelasmas. She also underwent a bone scan because of suspicion for histiocytosis, which was positive for uptake around the knee bones, and eventually underwent biopsies that confirmed ECD. The second case is a 49-year-old female, has started developing increasing fatigue and lymph nodes that were biopsied multiple times and showed reactive lymph nodes until 2018, where she saw us and finally was diagnosed with LCH. The key finding that I want you guys to focus on is also to see how many years elapsed before they were diagnosed in each of these cases. And this is not unusual. The diagnosis can be delayed by years and sometimes even decades in these cases. Although histiocytic disorders are rare, we don't know the true incidence. The cell of origin for histiocytosis may be multiple. It was thought to be classically originating from dendritic cells. monocytes or macrophages, but we are learning that some of them may be directly arising from the bone marrow progenitor cells or the parent cells. There are over 50 subtypes of histiocytosis. Some are very rare, some are more common than others. And they can all range from mild forms with a single lesion to multiple organ involvement, systemic disease, illness, hospitalization, and so forth. This is the classification of histiocytosis put forth by the Histiocytosis Society based on histology, phenotype, molecular alterations, and clinical characteristics. The L group is the more common one among the others. Includes the LCH and ECD, as well as overlap diseases. C group is cutaneous histiocytosis, except LCH, ECD, and Rosai-Dorfman disease, mostly includes xanthogranuloma family disorders. R group includes Rosai-Dorfman disease, which can be sporadic or familial. M group includes the sarcomas, histiocytic sarcoma, Langerhans sarcoma, and so forth. H group is the HLH group, which can be primary or secondary. In this talk, like I said, I will be focusing on the common ones, LCH and Erdheim Chester disease in adults, and we'll touch upon a little bit on the sporadic Rosai-Dorfman disease. Over the last decade, the discovery of recurrent mutations in the MAP kinase pathway in most histiocytic disorders has led to the way we think about them. Previously, they were thought of as inflammatory or autoimmune conditions, but now we think of them more as cancers. The first mutation to be discovered was the BRAF V600E mutation in half of the ECD cases, subsequently also found in LCH. Over the subsequent years, many mutations in the MAP kinase pathway beyond BRAF V600E have been reported in almost all cases of ECD and LCH, and more recently in Rosai-Dorfman disease as well. The discovery of these mutations has led to the categorization of these disorders as cancers. ECD was recognized most recently in 2016 by the World Health Organization as a blood cancer. This changes a lot of things for the patients overall because they get to see the oncologist, hematologist in a timely fashion and get treatments versus seeing multiple other providers who do not treat cancers in general. RDD for now is not included as a cancer, but there are some of those cases that can behave like cancers. The discovery of MAP kinase pathway mutations has led to successful use of targeted therapies. The first landmark study was a phase 2 study using vemurafenib in BRAF V600E mutated Erdheim Chester disease and Langerhans cell histiocytosis. 26 patients were included in this study, 4 with LCH, 22 with ECD with BRAF V600E mutation. By PET scan criteria, almost everybody responded, as you can see in the chart, waterfall chart on the right side. And this trial was actually the trial that led to the first ever approval of a drug for adult histiocytosis, was vemurafenib by US FDA in November of 2017. For patients without the BRAF V600E mutations, due to the evidence of MAP kinase pathway activations through other mutations, MEK inhibitors have been tried. This has led, the first landmark study for that was a phase 2 clinical trial of cobimetinib in 18 patients with various histiocytic disorders, of which 8 did not have the BRAF V600E mutation. And as you can see, regardless of the mutation status, presence or not, pretty much everybody responded. This has resulted in the designation of cobimetinib as a breakthrough therapy by the FDA, and it may be approved in the coming future for BRAF wild-type histiocytosis in general. Let us review the clinical and radiographic features now of these disorders. This is a graphic that we put together when I was at Mayo Clinic using data from 80 ECD patients. The goal of reviewing this was to see, are there any characteristic clinical features, presenting features that can help identify ECD and capture the diagnosis early. As you can see in this chart, ECD patients present with a wide variety of non-specific manifestations. The most common and notable one is bone pain, especially in the legs. It can be seen in half of the cases, but it's not very specific. Other unique finding, somewhat unique, is diabetes insipidus that can be seen in 20% to 30% of these cases. But overall, many other manifestations can be seen depending on what organ is involved. So really, there's no one finding beyond maybe diabetes insipidus with some bone pain that could lead you to think about ECD just by the manifestations in the clinic. So we put together this graphic based on our experience and literature review that basically shows that ECD is a head-to-toe disease. It can affect any organ system of the body, so it is important to do a thorough evaluation of cases. The most common and classic feature of ECD is actually involvement of the knee bones. It can be seen on a PET scan or a bone scan. It's seen in over 95% of cases. And that is almost diagnostic of ECD, but other organs can be involved as well. Other classical features are the hairy kidney that can be seen in half of the cases, endocrine dysfunction, diabetes insipidus being the most common, but other endocrinopathies can be seen in 2/3 of the cases. Central nervous system involvement can be seen in half of the cases. Heart involvement can be seen in the form of right atrial pseudotumor on an MRI, which is the ideal way to do it. But other classic features are these xanthelasmas that I mentioned, which are yellowish, orange skin lesions around the eye. You can have orbital involvement, pleural involvement around the lungs. Very rarely in men, you can have testicular involvement where it occurs in combination with Rosai-Dorfman disease. And the other classic feature is the coating of the aorta or any other blood vessels that can be seen on a PET scan or a CT scan. Here are some more images highlighting bone involvement with ECD. The bone involvement can be seen on CT scan, MRI, PET CT, technetium bone scans. It is important to note that classic findings are seen in the knee bones. So the traditional PET scan that is up to only mid thighs can miss this diagnosis. So we have had cases where we've undergone PET scans from not being from head to toe, and we missed the diagnosis of ECD was missed or delayed. And then we repeated a PET scan for the full body, including the knees, and that captured the diagnosis. So that's very crucial. Also important to know is any bone can be involved, including small bones of the feet. So head to toe imaging is very important for these cases. These are images highlighting the hairy kidney of ECD, where you can have this wispy infiltration around the kidney, and then the retroperitoneum can be seen on a PET scan as well. This is not particularly specific for ECD, can be seen in retroperitoneal fibrosis and IgG4 disease. But if you have other features, mutations, and so forth, this is good enough to qualify someone as ECD, but highly suspicious for ECD when these are seen in the clinic. Central nervous system involvement is another crucial one and differentiating feature of ECD as compared with other histiocytosis. Tends to involve the posterior fossa, the cerebellum, and other lesions in the pons, which can affect the gait, but can involve pretty much any other nervous system structures such as the spinal cord, nerve roots, pituitary gland, hypothalamus, as well as the cranial nerves. It is important to note that these lesions are also FDG avid if you do a dedicated PET scan of the CNS. Additionally, ECD can cause multiple endocrine deficiencies. This is what we call as invisible involvement because you cannot catch it with imaging. Patients may not have any actual lesions of the pituitary gland, but have diabetes insipidus and anterior pituitary dysfunction. As you can see here, multiple other hormones can be deficient, including thyroid, adrenal, gonadal deficiency can be primary, as well as through the pituitary. The other very important manifestation that is that has to be highlighted is the other quality of life and mood disorders, as well as psychological and neurocognitive disturbances in these patients. And we are learning more and more about this. You can see cognitive impairment in half of the cases to frank dementia in some patients. Psychological symptoms are very widely prevalent, including depression, anxiety, uncontrollable crying. Chronic pain is another issue that is poorly understood, but is widely prevalent, as well as chronic fatigue or sleepiness. These symptoms may or may not improve even after treatment of ECD. And now we are learning that these can also be seen in LCH, although there is work in progress to accurately define the prevalence of these complications. So it is important to ask patients about these issues. This chart now depicts the common presenting signs and symptoms of LCH in adults based on our experience. As you can see, the parallel with ECD is the diabetes insipidus, which can be seen in 10 to 20% of the cases. But other manifestations include cough, especially in pulmonary LCH patients with shortness of breath. You can have skin lesions, lump on the head because it tends to involve the cranium a lot of times, but other non-specific symptoms can be seen as well. The other manifestations of LCH, seen more common in females, can present as a single system disease, multi-system disease, or primary pulmonary LCH that is entirely smoking related. The manifestations of LCH are a little bit unique in that pulmonary LCH can present in the form of nodules and cysts in the lung. It tends to involve the central nervous system less frequently, but when it involves the cranium, it involves the dura, dural-based lesions, very commonly to be seen in the form of bone lesions. In contrast with ECD, the bone lesions of LCH are these scooped out osteolytic lesions that most commonly occur in the flat bones of the body. Skin rashes can be seen, and like in ECD, endocrine disorders such as diabetes insipidus and other hormonal disturbances can be seen. Very rarely, lymph node involvement can be seen. It's always good to rule out other concomitant lymphomas if you see lymph node involvement, and to make sure it's not reactive lymphadenopathy when you see lymph nodes with Langerhans cells. Some more images depicting various organ manifestations. Very rarely you can have true central nervous system involvement. There is a dreaded complication called as neurodegenerative LCH, which is very rare in adults, but can occur in long-term survivors of pediatric LCH and manifests in the form of learning disabilities, ataxia, difficulty walking and falls, and so forth. Pulmonary LCH can occur in multiple stages, almost entirely smoking related, can occur as nodules, cysts, or more advanced in the form of nodulocystic lesions in the lung. Another dreaded complication of LCH is the sclerosing cholangitis with rapidly increasing bilirubin level and cholestatic picture. Lesions of LCH are also PET-avid, similar to ECD and RDD, as you can see on the figure in the right side. A little plug about RDD here to make sure that we are able to differentiate between RDD and LCH and ECD. RDD is slightly different in LCH than LCH and ECD in that it is not currently considered as a malignancy. It can manifest as inherited Rosai-Dorfman disease with other syndromes seen mostly in children. It can be IgG4 related Rosai-Dorfman disease, as well as neoplasia-related RDD, which can occur in combination with lymphomas or in combination with Erdheim Chester disease. It can also be seen in concomitant presence with immune disorders such as lupus, juvenile rheumatoid arthritis, and other autoimmune conditions where it is called as immune-related RDD. But the classic features of RDD in adults, in our experience, is actually most commonly seen in the form of subcutaneous nodules, not in as much as a rash in over half of the cases, but lymph nodes can be involved as well in any part of the body. Other organs can be involved as shown here, but those are the most common manifestations of Rosai-Dorfman disease. While we traditionally thought of these three diseases as distinct entities, we are now learning that they can actually lie on a spectrum and can manifest with mixed features. So there have been reports of concomitant RDD and LCH, which is predominantly seen in lymph nodes. In the same lymph node, you can see LCH and RDD cells, LCH being the dominant one. ECD and RDD was recently described, seen mostly in older men with testicular involvement and with MAP2K1 mutations. LCH and ECD can overlap, mostly seen in young patients, over 80% being BRAF V600E mutated. Interestingly, the LCH component in these cases either occurs at the same time with ECD or after ECD diagnosis. So the knowledge of clinical and molecular features of these diseases is very critical, because if you see any of these features, it should prompt you to consider repeat biopsy of a new site to identify these other lesions. Let's switch gears to the diagnosis and workup. Histiocytic disorders have characteristic features on the review of tissue biopsies. When you do the biopsy and look at it under the microscope, some of the features are common, such as the histiocyte marker CD68, 163, which can be positive in each of these. S100 is another marker, which is usually positive in RDD, but can sometimes be seen in other two. The histopathologic diagnosis of LCH tends to be relatively easier because of the two markers, CD1A and Langren, which are uniformly positive in this disorder, but negative in other two. The emperipolesis, which is the engulfment of intact lymphocytes and plasma cells by histiocytes, is a characteristic feature of Rosai-Dorfman disease. But the highlight, the reason I marked these is to highlight that while LCH has two distinct markers, CD1A and Langren, ECD does not have really one marker that would definitely tell you that somebody has ECD. And these features can be seen in xanthogranuloma and other lesions as well. The factor 13A is usually positive in ECD, but can be seen in RDD as well. Emperipolesis is unique to RDD, but can be seen in ECD as well. So a lot of times the diagnosis is clinicopathologic, especially in ECD cases. Therefore, it is important to spend some time reviewing how can we diagnose ECD. The ECD diagnosis is clinicopathologic. What does that mean? That means that you have to make the diagnosis by reviewing the biopsy in conjunction with the clinical and radiographic features. And more recently, the molecular findings may also aid in the diagnosis. So you may have cases which have the classic bone involvement, but may not have the biopsy features, all of them for ECD, with or without MAPK mutations, and still be called as ECD diagnosis. Or you could have cases with xanthelasma or hairy kidney with the mutations without any of these features, and you can still have a diagnosis of ECD made. So it is not like other cancers where you just do the biopsy and ask your pathologist to look at it under the microscope and make a diagnosis of ECD. You have to talk to the pathologist and review the features in conjunction with the clinical presentation. In a lot of cases, sometimes, especially like pituitary and brain involvement, you may not have enough tissue at all to do multiple stains. In those cases, presence of a mutation on the tissue or even on the blood sometimes can help in achieving the diagnosis of ECD. This flowchart depicts the suggested workup for histiocytic disorders at diagnosis or at initial suspicion. The recommended tests can be broken down into laboratory tests, imaging studies, and some other tests. It is important to do CBC, electrolytes, other metabolic panel, but it's also important to look for BRAF V600E mutation now that can help in diagnosis as well as treatment. And now we recommend doing next generation sequencing for MAP kinase mutations and kinase fusions on pretty much all cases and after the biopsy. Sometimes you may not have enough biopsy tissue, so you may have to do blood-based analysis. It is critical to do a PET CT scan that is from vertex to toes in all cases, to make sure that we have all the disease sites captured, and also to find a site of biopsy, which the PET can guide easily. MRI brain and heart is recommended for ECD diagnosis because these can be missed on other imaging studies and can be asymptomatic. For people with isolated lung LCH or pulmonary LCH, chest high resolution CT is recommended. Other tests, depending on what the manifestations are, could be done. For patients with polyuria, polydipsia, it is recommended to do a full pituitary function evaluation, including gonadal and adrenal evaluation. For patients with pulmonary LCH, pulmonary function tests and echocardiogram may be needed going forward. So these are some of the basic tests that should be considered at the very beginning when you see these patients in the clinic. Let us talk about treatment of ECD and LCH in adults next. Here are the treatment options for ECD. Now, since for many years it was not known what is the pathophysiology of ECD, what is the origin of ECD, multiple varying treatments have been tried depending on who the patient sees, what is the clinician's preference, and so forth. The treatment options can be divided into targeted therapies and conventional agents. Targeted therapies include BRAF and MEK inhibitors, and conventional agents include immune therapies, such as interferon alpha, chemotherapy agents, cladribine, cytarabine. Anti-cytokine agents were used a lot by the rheumatologist, and other treatment options. Interferon alpha was the most commonly used treatment historically, but now we are moving toward targeted therapy in ECD. There is not much role of imatinib and radiation anymore in ECD, nor is the role of steroids as primary treatment beyond some symptom control. This table presents a list of commonly reported treatments in ECD with the type of study, number of patients, response rates, and some comments. As you can see, most of the studies are retrospective from single institution, but since the discovery of MAP kinase pathway mutations, we have 2 phase 2 trials of BRAF and MEK inhibitors that show almost universal responses. Other notable therapies are interferon alpha with varying responses. It is to be noted that pegylated interferon alpha may be better tolerated than interferon. Cladribine was another agent in terms of chemotherapy that has the most evidence with some sustained responses. Anakinra of the biologics has the most evidence, can lead to responses in milder forms of ECD, although not the preferred treatment approach, but other drugs as listed here have been used as well. This is the approach I typically use while considering treatment of ECD patients. This is also outlined in the ECD consensus guidelines published in 2020. It is to be noted that almost all ECD patients are in need of therapy at the time of diagnosis, but there may be a handful of cases with isolated bone involvement and so forth without much symptoms that can be closely monitored, although it is to be noted that they will need treatment in the near future. It is recommended to enroll in a clinical trial where possible, but otherwise, as you can see, the first fork in the road is looking at the mutational status. If the patients have BRAF V600E mutation, if that can be seen in half of the cases, and they have severe disease, and we need a quick response, BRAF inhibitor, vemurafenib or dabrafenib is recommended. If they have non-severe manifestations, I still tend to use BRAF inhibitor, and that's the preferred approach, but conventional agents are reasonable as well. There are cases who don't have the BRAF V600E mutation, and they have other MAP kinase mutations, except certain kinase fusions, where you can consider MEK inhibitor treatment, such as cobimetinib, trametinib, binimetinib, or you can consider conventional agents. There's very rare instances of kinase fusions, such as ALK, RET, or NTRK fusions, or CSF1R mutations. Those cases can be treated with specific inhibitors that are available, but it really depends on how easily they are accessible. Otherwise, you can consider using conventional agents as well. Now, there will be instances where patients are acutely sick and you don't have time to do any of these tests and you want immediate response. And in those cases, empiric MEK inhibitor treatment is very reasonable to begin with, but you can consider conventional agents as well. Similarly, these are the treatment options for LCH. The targeted treatments remain the same. For conventional agents, you can see there is combination chemotherapy, methotrexate, high-dose methotrexate plus cytarabine, vinblastine plus steroids, and some lymphoma-driven treatments. Single-agent chemotherapy includes cladribine and cytarabine, along with hydroxyurea, some immunosuppressive and immunomodulator treatments, and some other treatments that are listed here. So again, very wide variety of treatments that have been used historically. This table shows, again, the list of those treatments with the type of study, number of patients, and response rates. Targeted therapies are slowly accumulating evidence in LCH treatment in adults. As you can see, it's only a handful of patients in adult LCH that have been treated with targeted therapies on these studies, but the response rates are almost universal. But the part of the difference in LCH treatment and ECD is that chemotherapy still has a good role in the treatment of LCH and can lead to sustained remissions or even cure in a subset of cases. The preferred chemotherapy for LCH is cladribine or cytarabine. Cladribine, on average, we do 2 to 4 cycles of cladribine, but the response rates are high and can be used in newly diagnosed or relapsed disease. Vinblastine and prednisone, one point I would like to make is a lot of it is data is driven from pediatric literature. In adults, there was a study that showed very high relapse rate in patients with bone LCH with vinblastine prednisone. The other concern is the tolerability of vinblastine causing neuropathy, which may not be tolerated in adults with prolonged treatment with vinblastine, but it's still certainly one of reasonable treatment approaches. More recently, methotrexate and cytarabine have been combined in a Chinese study showing high response rates. But of course, there is a higher risk of febrile neutropenia and complications due to the cytotoxic nature of the treatments. Notable mention is zoledronic acid, which I have not used myself, but has been reported to be of some benefit in terms of symptoms in bone-only disease, but we don't know of its efficacy in other organ involvement in LCH. The treatment algorithm for LCH is not as straightforward as it is with ECD, just because LCH has a wide variety of manifestations. It can present as a single site disease, it can present a lung-only disease, it can present a skin-only or multiple organs. And it really depends on who sees the patients and what treatments they're comfortable with. But the way I tend to think about LCH is if there is a single lesion that is amenable to surgery or or just local treatment such as skin or bone in a safe area, you can do radiation or surgery. But there are cases which have single lesion in the brain, liver, and so forth that may need systemic treatment. For primary pulmonary LCH, the number one treatment is stopping smoking, and that can result in resolution of the features. However, we all know that it is not easy to quit smoking, and there are cases where even after quitting smoking, there may be persistent symptoms. So in those cases, systemic treatment should be considered. So for multifocal or multisystem LCH, you can use chemotherapy such as cytarabine or cladribine. But if immediate response is needed, and if there are critical organ involvement and there is BRAF mutation, you can consider a BRAF inhibitor. Or if there is no BRAF mutation, you can consider a MEK inhibitor, similar to what we did for ECD. There are patients who can have multiple sites of skin and can be treated with immunosuppression, such as oral methotrexate or Hydrea. Similarly, for 2 or 3 bone lesions, can be treated with radiation up to that mark. But it is certainly reasonable to use chemotherapy in multifocal bone disease. Over the last few years, we have also learned that patients with ECD and LCH are at a high risk of developing other cancers. The first study was in ECD and in mixed histiocytosis that showed that there is high risk of developing other myeloid neoplasms, other blood cancers, such as various leukemias, myelofibrosis, and MDS. Approximately 10% of the cases were found to have these other cancers. More recently, we found that in LCH also, both in pediatric and adult LCH, there is a higher risk to develop multiple cancers, which can be blood cancers or solid organ cancers, compared with non-cancer population, as shown in the figure on the right. Commonly seen are Hodgkin lymphoma, non-Hodgkin lymphoma, and leukemias, ALL, as well as AML, depending on what treatments the patients received. But various solid organ cancers can be seen as well. This has implications for follow-up and monitoring of the patients because now we have good treatments that will prevent mortality from the disease itself. So it's important to make sure that we also keep an eye out for other complications that could affect the survival. So once treatment is started, it is important to monitor for disease response and also complications from disease itself, as well as treatments. If the initial disease is PET scan, is avid on the PET scan, it is important to repeat the PET scan every 3 to 6 months until you reach a best response. Beyond that, it is unclear how to best manage it. It really depends. You have to individualize it. If the disease is stable for a few years, you can space out the imaging studies or even stop doing it if the patient is doing well. You may need other CT scan or MRIs alongside, depending on what organs are involved. It is important to not miss endocrine evaluation, especially in ECD cases. It is known that patients, even if they are responding to treatment, they can develop new endocrinopathies down the road, and may not improve even after treatment of the disease, and they may need hormone replacement going forward. Like I mentioned earlier, very important to not ignore other symptoms that may not get better despite treatment of ECD and LCH. Chronic pain, mood disorders, and other symptoms such as dementia and memory issues may warrant supportive care and pain clinic management. Depending on what treatments you use, you may have to monitor for the toxicities. Targeted therapies have unique toxicities of the heart and the eyes and the skin, so they may need multiple evaluations in parallel. The other thing I want to make sure that everybody understands is to just keep an eye for second cancers. It doesn't mean that we have to keep doing testing to find them, but if patients complain of new symptoms, not to ignore them and to take them seriously and look for other complications that can develop down the road, because ultimately the goal is to improve overall survival and quality of life of the patients. So let's go back to our cases that we initially discussed. If you remember that 20-year-old female, she was found to have BRAF V600E mutated Erdheim Chester disease. After the diagnosis, she was started with vemurafenib. Unfortunately, developed pancreatitis as a side effect of the vemurafenib. So switched to infliximab, which did not result in a response, but yielded stable disease. Subsequently, she was tried on lower doses of a BRAF inhibitor, dabrafenib, in combination with a MEK inhibitor, which is also a reasonable approach to consider. And she approached a near complete remission and has been on it since then. The other patient did not have any mutation in the LCH. In 2018, she received cladribine for 4 cycles, achieved a near complete remission, continues to struggle with a lot of fatigue and other symptoms requiring some prednisone doses and some off and on lymph nodes, but she has not received any other systemic therapy since then. But this case highlights the other symptom burden, such as chronic pain and quality of life issues. But the risk of mortality from LCH itself would be low in these cases. LCH and ECD would be low. So let's touch base a little bit about the challenges and where do we go from here? What are the challenges that remain in the diagnosis and management of histiocytosis? Despite all the advances in the understanding of histiocytic disorders, one of the biggest challenges is the timely diagnosis. And especially in ECD, the diagnosis can be delayed from months to years and multiple biopsies may be needed to achieve a diagnosis. Part of the issue is, as I highlighted, that you can't just look at the biopsy under the microscope in all cases and make a diagnosis. The other issue is that as clinicians, as physicians, we are not routinely taught about these disorders. I developed an interest on my own in my practice and learned about these disorders, but it is not usually discussed in textbooks. We don't know how common they are. There is no uniform reporting of these disorders. There are no clinical or lab findings that will help us highlight that this case is ECD or LCH. And on top of that, there are multiple mimics of these diseases. These patients end up seeing multiple other providers, clinicians, before they end up seeing a hematologist or oncologist, who usually is the last physician to see them. And by then, a lot of organs may have already been involved. It is important in ECD to know that it can mimic various other disorders and can delay diagnosis by many years, as they can be called as MRH, glioma. These are the cases that I've seen in my practice as well: retroperitoneal fibrosis, MS, and meningioma. So it's important to be aware of other symptoms that can coexist. Given the varying presentations of histiocytosis, it is important to spread awareness among various specialties about these disorders, because a lot of these specialties will be the first ones to see the patients. So if they are aware of these constellation of findings, a lot of times they can be the ones to actually capture the diagnosis and alert the clinician to do appropriate additional workup to catch diagnosis early. So in an attempt to improve the diagnosis and outcomes of histiocytosis, I was able to help establish the first of its kind histiocytosis working group with the help of my mentor, Dr. Ronald Go at Mayo Clinic. And we continue to collaborate. Since I moved to UAB, we expanded it to UAB as well. We review cases on a monthly basis, and we learn a lot from those cases and have accumulated considerable expertise in those. We ultimately created a guideline document based on existing data and our own experience to help the clinicians from all subspecialties to guide them regarding the features of histiocytosis to capture diagnosis in a timely fashion. Here is the list of key features that we identified that should alert the clinicians to suspect ECD and LCH in the differential diagnosis. We divided them into major features and other features. So if there are patients who present with, who are found to have these bone findings, osteosclerosis, or punched out lesions of the skull, hairy kidney, lung cystic, nodulocystic lesions, and a biopsy showing atypical histiocytic infiltrate, that should alert to the suspicion of histiocytic disorder, and additional workup should be conducted. These findings, these few images are very, very critical to remember, because these can help save many years for the patients to be diagnosed in timely fashion. Another challenge is with the advent of targeted therapy is how long do we treat the patients and at what dose. Although we have made remarkable advances in the survival of histiocytic disorders using these targeted therapies, there is a concern that these are not curative treatments. In a French study of ECD patients, it was found that 75% of the patients who stopped BRAF inhibitors due to side effects or having a response to some degree for over 9 months, they had a relapse within 6 months on scans. Fortunately, all of those patients were able to capture the response again after restarting the treatment. So, the risk of disease relapse is there, but it may not apply to all patients. So, in my practice, there are patients that are reasonable to consider at the lowest possible dose based on their side effect and response. And it can be managed like that for a long period of time. If patients are having issues with side effects, you can do drug holidays, but it's important to have a plan to make sure that you follow up, to not let it go for many, many months without following up, or if the patients are in a sustained remission for a long period of time, but you need to continue to monitor them closely. In the future, we don't know if there is a role of combining sequential or a combination or sequential chemotherapy and targeted therapies to potentially achieve cure, and that is being looked at in the future. We have multiple ongoing efforts to improve the diagnosis, treatment, and overall experience of patients and families affected with histiocytosis. First and foremost is the patient care. We continue to review cases and do research in Histiocytosis Working Group, which now includes UAB, where I am, and Mayo Clinic. We have collaboration with the patient support organizations to educate the community on a whole with webinars like this. We're finally able to put together the NCCN guidelines that are key in the US. They're important to harmonize the management of histiocytosis. Multiple other translational studies are ongoing to look for new targets for mutation and to look for ways that you can do blood tests to see if targeted therapies can be stopped in a prospective fashion to achieve a cure. My particular interest is in the overall experience of patients and families with histiocytosis, to look at the burden of symptoms, the chronic health conditions, second cancers, mortality from other causes now that survival of histiocytosis is improving, chronic pain, mood issues, and quality of life. And then we have ongoing parallel biorepository for these cases, and we collect samples alongside. To summarize, I think I lost the slide. Give me 1 second. To summarize, it's important to know the organs involved by doing a full body PET CT, other imaging studies as indicated. Gene mutations are important to know based on molecular testing, BRAF testing, NGS, and so forth. It is important to monitor toxicities of targeted therapies very closely. As we use it more and more, we may learn of new side effects. It is important to not ignore the other symptoms. Even if the patients are in remission, they may have ongoing mood disorders, depression, anxiety, pain, and it is important to watch for other chronic medical conditions, as that can really affect their quality of life. Please be open to getting second opinion. I'm happy to collaborate with any of the clinicians if they have any questions about the patients. We all learn from collaborating, especially in rare diseases. Finally, I would say, please participate in clinical research. Can't tell you how much of these things we learned because of the patient's willingness to enroll in studies. You know, most of the organizations have registries that you can enroll in and can be a part of the ongoing studies to improve outcomes of the future patients. I would like to thank the OR Asociación, ECDGA, and the Histiocytosis Association for all the work that they do for the histiocytosis community, families, and for spreading awareness. I thank the patients and families who participate in ongoing studies that are critical to improve our understanding of these rare disorders. Special thanks to my mentors at UAB and other institutions that I collaborate with, the Histiocytosis Working Group members, and all of my funding and support that makes it possible to do all the research ongoing and in the future. Thank you.
Well, Dr. Gaurav, it was just amazing. Thank you so much for this enormous masterclass for all the adult patients. I am really sure that they will not have enough. Thank you for these words and all the work that you have shown. We have a special gap with them, and this is really going to be something that they will really appreciate. So I want to say thank you very much. I want to also address for you some questions, if you are okay.
Yes,
there is some of them we already answered to them. Okay, during your talk, we already answered to them. One of them is in Spanish. I will translate live. It's related to if there can be done, if there is a way to give back the capacity of the pulmonary lesions once you have some pulmonary lesions. Are there any treatments, complementary treatments that you can do, like when you are now affected by COVID, for example, right? After you get COVID infected, if there is something that you can do, kinesiology, they are suggesting here, if there are if there is a way to improve your capacity, your pulmonary capacity.
Yeah, are you asking specifically for pulmonary LCH?
Yes.
Yeah, so I think, you know, it's very important to work closely with the lung doctors that you see. You know, unfortunately, once we don't have great ways to improve the functional capacity beyond treating the LCH and seeing if it improves. There are cases certainly that have advanced lung involvement. And, you know, the best we can achieve in those cases is to achieve stable disease. Certainly with COVID, those patients are potentially at a higher risk of complications. So I would just suggest, you know, just being extra careful, get the vaccination if it is available nearby you. Beyond that, I am not aware of other complementary treatments. There is lung rehab that patients with COPD do. Maybe ask your lung doctors about that, especially in pulmonary LCH, which is isolated and smoking related. The number one thing is to quit smoking altogether. It's very strong association with smoking and pulmonary LCH.
Thank you very much. If there are other questions, we will leave them for the end after Diane's and Jessica's talk. While Diane is preparing her presentation, let me say thank you for all the people connected from Greece, especially to Dora and Mariana from the Artemis Association, which are connected now. To some of the doctors that I recognize from the list, Dr. Diaz, Dr. Calle, Dr. Ordeneta, Dr. Subizarreta, and also I see many patients connected from Guatemala, from Mexico, from Paraguay, from Chile, from Argentina, from Spain. It is really, really great to have so many people on board interested in your talk and in general in the histiocytosis. So. And also, let me thank the translator and the interpreter, because it was not easy to interpret your talk. And this is something that I personally did in the past, and it's really complicated. So thank you very much, Maya and Paola, which will continue now with Diane's presentation. So Diane, all yours.
Thank you so much. I appreciate it, and it's a pleasure to be here with all of you. Thank you, first of all, to the OR Association for organizing these important conversations. Thank you, Dr. Goyal, for your fantastic presentation, a lot of really great information. And thank you to the Ecd Global Alliance for your partnership as well. I'm just going to spend a couple of minutes telling you a little bit more about the Histiocytosis Association and the resources that we can provide. We are committed to addressing the unique needs of patients, families, and physicians who are impacted by histiocytic disorders. And we've been in operation since 1986 and have been able to connect patients with physicians and resources from all over the world. We are based in the United States, in the state of New Jersey. And I have been the executive director since February of last year, and also I'm an LCH patient. So I was personally able to take advantage of the amazing resources that the association has to offer through my own personal journey. So our mission is three-pronged, and I broke it down into 4 different places that we provide support. So we support research, clinical trials, and registries and other studies related to all histiocytic disorders. We provide emotional support to patients and families, educational resources on all of the histiocytic disorders, including a physician's directory, and I'll dive into some of those programs in just a moment. And then we seek to share results, key learning, and patient experience with the community to expand knowledge. So the impact and resources that we have helped over 19,000 patients, families, caregivers, and physicians across 119 countries. And that, like I mentioned, has been since 1986. We have a physician's directory on our website that is interactive, and there's a picture of that on the screen where you can type in your location, and if you have a diagnosis, you can enter that as well, and you can find physicians local to you, and that helps to provide access to experienced clinicians, which can result in better outcomes. A question did come up on the Q&A that I wanted to address here, is that if you don't have a physician that's within your local area, you can contact the association or the Ecd Global Alliance or the OR Asociación, and we can help connect you with physicians who are willing to consult your treatment team locally. A lot of times, as Gaurav mentioned, there may not be somebody who's experienced with histiocytosis in your area. However, physicians are often very willing to consult, and that way you can get your treatment locally, but have the experience of someone who has treated patients with histiocytosis. We have detailed information on clinical trials on our website if you want to learn more about possibly enrolling or participating in a trial. We also have a resource directory containing information on a variety of different topics, including insurance, financial support programs, genomic profiling, registries, bone marrow transplants, and we also have information about all of the different family advocacy groups that are around the world, so that you can find local support as well. And we have a scholarship program within the United States that has been around since 2019. We've granted 10 scholarships towards undergraduate education for Histio warriors and their families. We also have an education and connection section on our website where we have a variety of different resources, including a podcast that seeks to go beyond the diagnosis and touch on topics, including advocacy. For example, we recently interviewed the Every Life Foundation to talk a bit more about the STAT Act, which is trying to improve the drug development timeline within the FDA. We have regional meetings whenever possible. We also have our Facebook page and Instagram page where you can connect with other people in the Histio community. We have an educational webinar series that take place throughout the year, and often in partnership with other organizations, just like today. And then there's an informational video section that includes a collection of educational talks highlighting common questions about histiocytic disorders. It features 13 physicians and scientists from around the world who are considered leaders in the field of histiocytosis. The association is very committed to research, and for over 35 years, we have served as secretariat to the Histiocytosis Society, which is another organization. It's a group of physicians and researchers from around the world that are focused specifically on histiocytic disorders and research that is necessary to advance treatment and patient outcomes. This partnership that we have is demonstrated through our annual research program, which opens up every year, and decisions that are made by the Histiocytosis Association's Board of Trustees are based upon the reviews and evaluations of these competitive grants by the Histiocyte Society's Scientific Committee. If you'd like to learn more about that, we also have a section on our website that talks through our annual research program. Since 1990, we have funded over $7 million in research, awarding 190 seed grants to investigators around the world. Like I mentioned, we open that program annually, and the applications that we receive face an extensive evaluation and peer review process that's modeled after that used by the United States National Institutes of Health. There's information about all of the grants that we've awarded on our website if you'd like to see the different research advancements that have taken place throughout the years. And I just want to say thank you so much for all of you for being here. If you'd like to connect with us, you can sign up for newsletters on our website at www.histio.org. You can also find us on Facebook, Instagram at the links highlighted on the screen. And if you'd like to connect, you can also email us at info@histio.org. We look forward to getting to know you. And again, thank you so much for allowing us the opportunity to spend today with you.
Thank you so much, Diane. It's really a pleasure, to work with you, to be in contact with you for these years. You are also an example, a personal example for me, that for all the patients as well, that there is something to be done, and we have a role to play, and really we can affront this, the diagnosis, the treatments, and then also move on and help others. So thank you so much for your presentation. It's a real pleasure. I have now, we have Jessica. So Jessica Corcoran is going to present now about if there are any questions to Diane, to Jessica, or to Dr. Gaurav, again, we will do them at the end of this session, okay? So after that, we will continue to answer some of the questions that are arriving. Again, you can propose them in the Q&A, chat box, or in the chat as well. Jessica, you can now share, if you can share your slides. Perfect. Now we see them.
Okay. Hi, everyone. And thank you again to the OR Association for inviting us to be a part of the conference. We're very excited to be here. I'm the executive director, as he mentioned, of the Ecd Global Alliance, and we are based in the southern part of the United States. We offer global support to the Erdheim Chester disease community specifically. This is accomplished by providing the education on the disease, research funding, patient family resources, emotional support, and as well as referrals and collaboration for the physicians involved in the care of the patients. Over 700 families have received support from the Alliance since it was formed in 2008. These patients represent 65 countries. The Spanish-speaking community we represent are provided an opportunity to connect with the other families virtually. We try to meet quarterly each year. This was our first year, and we've been really enjoying meeting everyone and having that connection. The emotional support that this offers can help patients and family members feel less alone and better able to advocate for themselves when they go back to their doctors. These quarterly meetings are also held in Spanish with a Spanish-speaking physician. So he comes on and actually answers questions for these patients. He has knowledge in histio diseases and the care of the patients that are affected. So any patient or family member is welcome to join that chat. I recommend you sign up with us to receive the invitations in your emails. And so also other Spanish materials are going to be coming up soon. So we'll be able to get those to you. We just want to say to the doctors listening, please consider referring your patients to us so your patients can benefit from the services that we provide. We also hope that you will register with us and join our community of dedicated and committed clinicians and scientists committed to helping the histio patients. The card you see is, it's a little card, it's kind of business card size that we offer to the physicians to be able to give to their patients in the office when they come for their visits. So if you need some of these cards for your office, we'd be happy to mail you some. Just give us an email. In addition to patient support, the ECD GA also reaches over 1,300 medical professionals from around the world. The Alliance also created a ECD Care Center referral network that includes 35 institutions in 13 different countries. The identified physicians at these centers are committed to helping patients and providing consultation services to other physicians, as Deanna mentioned earlier. In order to serve adult histio patients with the best possible care, the Alliance continuously seeks to fill the gaps that we have in the referral network. And currently there actually is no Spanish representation within our network. So please get with me. We'd love to see a center in Spain, Mexico, Argentina, or any Spanish-speaking country. Would be very beneficial to our community. Researchers interested in histiocytosis are awarded research funding annually. The Alliance has awarded over $750,000 to fund seed projects that are mostly concentrating on ECD, but we also accept other histio applications as well. An annual international symposium is also held each year. This meeting allows clinicians, researchers, support professionals to come together and share their experiences and findings and share their case studies and things like that to talk about treatments that can be most effective for those patients. This is a one-day meeting and we host it in different cities each year. The return rate on this is roughly 100% because those in attendance are commenting on the value of what they've learned, and more importantly, the collaborations that were made at the meeting with other physicians that are very skilled in these diseases. So the Ecd Global Alliance is committed to building bridges with other advocacy organizations like the OR and the HA, and these unions will provide patients and families more support, bring more awareness to these rare diseases, and with your help, we can do support for these families as well as educate the doctors that are less familiar with histio. So we really appreciate your support. Thank you to the whole team for putting on the webinar, and especially for the physicians that are in attendance today, and the patients and family members as well. We just thank you for listening and being a part of the community, because just participating in these things, it makes the whole community have hope, because they know that you're out there and you care about them. So we thank you for your dedication to these patients. So please consider contacting us to get on our mailing list, get invitations to meetings. And our referral network is an excellent network for consultations. So thank you, and I look forward to working with you.
Thank you so much, Jessica. Thank you for your presentation. You know, I am a guy that loves to steal ideas. Normally, I have my own, but normally I also steal. And when I started all the emotional support plan for families and caregivers, I also has been seeing your work, all your work that you were doing related to patients, to caregivers, and it also inspired me a lot. I believe that many of the things, and that's why I think that it's so important to work together, is that there is so much work going that already has been done. So it is in our hands to really just take it and translate it in our own language, or give ourselves support. And so this is really great. And I even participated in some of your activities and in some of the talks, and they are really similar to what we do. So I hope that, as you know, in the future, we keep collaborating and do much more activities together. I don't know if we have answered all the questions. For example, Dr. Gaurav, there is one from Blanca Diaz here. If you can comment on the liquid biopsy and its role in LCH and ECD.
Yeah, I responded to some of them. So I responded to this one. Really, you know, you can consider that in cases where tissue testing is not possible, liquid biopsy is done by blood testing. There are instances where you can identify mutations, especially BRAF V600E, by blood test, where it is most helpful. But if the liquid biopsy is negative, that does not mean that the patient does not have a mutation. So, you know, it's not 100% absolutely correct, but if you find a mutation, it can be very helpful for diagnosis as well as treatment.
Were there other questions that you want to take from the
chat,
for example, and also answer them verbally, because maybe some of the people that are in
some
the
of
chat,
them are more long answers, so I just thought I'll discuss. So Deanna translated, sent some of those. So the first one is, when we are in remission, what test do you recommend for the controls? In my case, they are opting for analytics and ultrasound to reduce the radioactivity of the PET. So yes, so you know, the concern is real, because a lot of them are young patients. Like I said in my talk, that once you achieve a stable remission, the way I practice, I start with initially every 3 months or so. If they're continuing to respond, I space out to 6 months, then every year. Then if they make it a couple of years, then I just stop doing imaging and they're doing well clinically. I focus on their symptoms only. If they have new symptoms, that is when I do further imaging study based on whatever they have complaints about. The common tests I do is just basically lab testing, monitoring in parallel, CBCs and metabolic panel electrolytes, but that's pretty much it. The hormone is another hormone evaluation based on symptoms. If they already have hormone abnormalities, then that needs to be monitored in parallel because they may continue to need that. The other question is, when can we say that we are in complete remission and the fact that there is no risk of histiocytosis being activated? That is $1 million question. I wish I knew the answer to that. I would just say that, I guess the question that it's trying to get at is cure. It's a tough one to directly say in clinic that you've been cured of histiocytosis. What we know in ECD as of now, based on the targeted therapy data we have, that you can put patients in complete remission, which means that you have had multiple scans that don't show any more active disease. But it doesn't mean that the disease cannot come back. The other important thing I want to make sure that people understand is that just being in remission from the histiocytosis is not enough anymore, because we are able to achieve that. It is important to have a good overall health status. So quality of life, lifestyle management, because heart disease, lung disease, infections, those things can happen. So the things that you can prevent are very important. Vaccinations are important. So it's not like if you don't have the ECD active anymore that you cannot have other problems. So that's really the main overarching theme here. Remission typically is based on the imaging. You can say partial or complete remission based on the scans. The next question is, I think I answered to you, is the cholesterol question in ECD. There is some data that ECD patients tend to have more cholesterol deposits in their coronary vessels around the heart. And it may be potentially due to the altered metabolism of cholesterol in ECD itself. It is reasonable to just monitor your cholesterol levels and your overall heart disease risk. And, because that will affect your overall survival. And if you had developed heart disease. So it's important to do that, do a stress test and things like that. Beyond that, there are no other tests that are needed to screen. But if you develop chest pain or other heart issues, definitely would be aggressive in management of that with your heart doctor. The lung one I answered. The question
there is one also here. It's in Portuguese. I am not as strong as in Spanish and in English in Portuguese, but I will also try to translate it. It's from Renata from Brazil. And I also take the opportunity to say and send hugs to Simone in Brazil. If it's possible to do a BRAF testing on fresh biopsies or in biopsies that are conserved in formal.
Yeah, so you can do BRAF testing on either of them. Of course, the older the biopsy sample is, there is a chance that you may not be able to do it, but with immunohistochemistry, we are able to do that even in old samples. The critical part to remember is if it is a bone biopsy, typically the way the bone biopsies are processed is they get decalcified and that damages the DNA. So that can be a tough one to get a BRAF test on. So if the BRAF is negative, that doesn't mean that it doesn't help us. Unless it's positive, it helps us. So the bone biopsy specifically, there is guidance to do it to have a sample of the bone biopsy in non-decalcified manner or EDTA. And we have mentioned that in the guideline document specifically. So, but other than that, you can do it on old FFPE samples. But, I try to do it on more recent biopsies. Doesn't have to be a new biopsy if that's the question.
One thing I suggest also to the participant, if they have more questions, okay, or during this talk, I am sure that there will be more questions coming up, doubts, comments, okay, you can write us, okay, if you want to get in touch with one of the panelists, do it via our contacts. You all have our email because you received this invitation, so you can try to write us the question and we will forward it to Dr. Gaurav or other specialists that work closely with us. I also take the opportunity to thank Jorge Breyer, which is also in the room of the panelists. and I know that he collaborates with you, Gaurav, in some cases.
Hi, Jorge.
So he's also listening to this talk, and I want to thank him. I don't know.
Hello, how are you?
Good, thank you. You can probably answer a lot of these questions better than me.
No. No, Erdheim Chester.
So I think that probably we will leave it here, okay? Also for the sake of the interpreters, because I suffer for them currently. I cannot believe the work they have been doing. I was listening to all the interpretations as well in Spanish, and I don't have enough words to thank them. Maya, Paula. Paula used to work with me also in my previous work, so I am happy also to have her on board in this adventure. Again, thank you very much, Jessica. Thank you very much, Diane. It's an honor and a pleasure to work with you, to collaborate. I am sure that we will continue to do this kind of things in the future. We will try to organize them even better if possible. But this thing of also opening to interpretation, it's opening a big door for us and for to really bridge all the gaps that were that we had in previous meetings. I will take this opportunity as well before closing. I didn't say to talk about the next talk, which will be the last talk finally. I don't know if maybe it was too many journeys, but in any case, we have the last one dedicated to patients and to caregivers. Okay, it will be next Wednesday, the 29th, at the same hour at 7 p.m. Sorry, here in Spain, in Europe, and at 2 p.m. in Argentina. We will have the therapists that are working with us in the support plan. Beatriz and Laia, that many of the people connected today also know them. We will talk about all the support that we can give to patients, to families, and why it is so important that we also take care of the soft part, not only the medical part, but also taking really good care of ourselves, well, to take care of ourselves. Let's leave it at this. And also in this session, I will chat with Fabio Topa. Fabio Topa is the president of my homologo in Argentina, a good friend of mine in Buenos Aires, and we will be chatting about the work that we are doing as associations also the last years. So I invite you all to participate. I will send a couple of days before the invitations to all of you. And we will send also to all the people registered the video of this talk after we finish and we edit it. And it will also have the possibility to have it with subtitles in different local languages. So again, thank you very much. Thank you, Jessica. Thank you, Gaurav. It was a pleasure, huge pleasure. I hope to do much more in the near future. Thank you, Diane.
Thanks for having me.
Thank you, everyone.
Have a good day.
Bye. Oh,
you
bye.
too.
You too.